welcome to the meeting, and I'll show you the case. So this was actually came to us about a month back, 3 weeks back, with angina of 1 year standing. The LV was okay, and that's the angiogram that we did, which shows LAD heavily calcified with disease, and there is circumflex. The OM has a stenosis, and we see RCA filling through collaterals. You see RCAs, distal RCAs filling through collaterals. Yeah, next.
LMC osteal lesion?
Not really.
Okay.
Not really.
Can we see that again? The
So
LMCA?
that is how it was. So the LAD. Yeah. So the left was quite heavily calcified, and it was getting severe in the mid segment, just at the point where the septal is coming out. So at that stage, go ahead. We plan to do the LAD and OM. Actually, I first just tried to explore the RCA, wondering that maybe the RCA is not acute occlusion. But when I touched the RCA with a regular wire, there was no movement. So I could sense that this is a CTO. So understanding that this is a CTO, and if it has to be done, then maybe we will need to fix the LAD, because LAD is giving collaterals towards the RCA. So we did the LAD, and the OM was also severe. LAD is also severe. So go ahead, and then we did this. In fact, the LAD needed a, go ahead, keep moving forward, please. So LAD needed a rota. So that was the RCA. So next. Okay. So then we did this, and then finally we had a good result on the LAD and the OM. Both were done, and I thought the collaterals would develop with some time, and we will do the RCA stage 2, and that is how the patient is here today. Okay. So now can you show us the angiograms of today? Incidentally, so you will see the final final on the LAD and RCA. No, first angio, please. So that is the LAD. Go back, first angio.
So
okay.
You fixed the LAD and OM
no,
2 months back?
The current angiogram.
That's what he said? 2 months?
No, I think I did it about 3 weeks back.
Okay.
3 weeks back. So that's the OM stent that you see. OM is okay. And next view. So that's the LAD. So LAD has a stent. Actually just till the level of the first septal. So that is a point. And then you have septal collaterals, which are filling the RCA, and the RCA is retrogradely filling a reasonable length up. If you can see in the AV groove, it is rising up. And then there is an atrial branch that is coming out at that level. Next, please. So we did the bilateral injections. Next. Continue, show the complete injection. So that is the right coronary rising in the AV groove all the way up.
Yeah.
But the RCA occlusion is almost ostial. You see, that's the issue. Okay, go ahead. Next. So move forward. So now with that thing there, what I just did a few homework exercise, but so the RCA wire is not moving as easily. So because of the presence of these collaterals, well, I just did a XTA.
Okay.
I have not taken stronger wires.
We see that
I considered that maybe I'll do the...
Dr. Goel, we see on dual injection
yeah.
that it's a short CTO of maybe 15 mm.
Yes. No. It's not as short. No, it's not as
Can
short.
we
It
have a
is
look
at
at the?
least 30 mm.
Can we
It's
again have
at
a look
least
at the
30.
dual injection?
Okay,
Can
go
we?
back. Go back. Go back. Are you going back? One more view. LAO view will tell us the real length. So it is at least 20 mm there, if you
Okay.
see. Okay? And the issue there is that it is heading upwards and the stump is very small, so there is no support there. Okay? So I have not tried much antigrade. I just
So
then I moved to retrograde. I thought because of the septal collaterals, maybe it will be better to do it retrograde. Now I'll show you what has happened actually.
Dr. Galasi, you have
Move
any comments?
forward.
I think that the most complex part of this CTO is that the CTO is, the body of the CTO is exactly in the bend of this artery, in this proximal part of the CTO. Of
Yes,
the
that is
RCA.
the problem.
So this is the most difficult
Yes.
part. So this is, needs probably bilateral approach.
Dr. Goel, one small concept. You had stump
Ah.
of RCA is visible.
Yeah.
Lesion is short. Why don't you try integrate
Ah.
first? Short lesion, stump
Oh,
visible,
lesion is not short, that's what I'm telling you, and it is in a bend.
at least 20 millimeters.
Whenever you
20
have to
millimeters.
try
Very
antigrade,
short.
no. You have to understand. What I'm saying is the same shot, the same. If I can do, you just see what has happened. Now I think I will have to do antigrade wholehearted. I'll tell you what all has happened.
I just wanted
The
to ask
thing
regarding
is,
the left main
you
ostium.
just
Dr. Goel, your left main ostium, is there a small dissection there?
No. There's nothing there. Well, there are some calcium which is there. You see something.
Guiding
Yeah,
is
you
pointing
see some,
upward,
but
left
I
main-
think
left
the
main
pressures
move,
are
and
okay.
there is plaquing in left main base also.
One suggestion, Dr. Goel.
Actually, if you want to go into the LED, it has to point upwards. If you start pointing it flat, then it will start going towards circumflex.
Dr.
That
Goel,
is
one
that
suggestion.
is the issue.
Antigrade
Okay.
we will try as
Yeah.
a preparation. Because retrograde, the angle between the LAD and the septal is so 90 degrees. You have to take a dual human catheter for entering
Yes.
the entry point of the septal collateral.
So we leave it
So
to you,
that
Dr.
is what
Goel,
it
how
is.
you are going to do it. But what me and my co-chairs feel.
No,
and
no,
some
no.
of the people-
I have done a little part.
Okay.
I did a little part. I'll show you that, and I'll tell you the problems that have been there. So, as expected, I was thinking that we'll go through the septal collaterals. So, the microcatheter, the Corsair Pro, was not letting the wire get into the septal. Okay? So, what I have done, you see, through a angled microcatheter, the supercross, that is the way that the wire went in. Can we see the next one? Yeah, that's the angled microcatheter. So the wire did go, and I could select the branch also. This is a C-on wire to get into the move forward in towards the distal RCA. But now the problem that happened, now this catheter was changed to, so the supercross was withdrawn, and then we got back to Corsair. But the Corsair would not move into this branch because this is coming through the struts of the stent. This
would you
is
like to
coming
change it
through
to
the
caramel?
struts of the stent. No, well, I can do that, but the problem is there is a bend and the stent strut is there at the end. If you see in this view itself, the stent is 2 millimeters beyond the takeoff of the septal. So I thought I will dilate it with a balloon. So 1.5 balloon I tried, it did not go in. Then I tried a 1.2 balloon, that also move forward. Move forward, please. Last का flow recording है? यही है. So in that deal, the 1.2 when I was putting in fact, it pushed everything out. So I am now back to square one. This is the 1.2 coming in.
Okay.
So because of that coming now, Dr. Galassi, do you have a thought? That's what's happening. You see that? It's not going in. So I thought I will take a guide liner and get some more push. But before I could do that, this has just come out. It has just come out.
So,
You see that?
So this is where you are
So
right
I have
now.
to repeat the whole exercise.
Okay.
Yes, so I'll have to repeat the whole exercise, or I take a committed antegrade attempt.
Right. I mean,
So now my thought is to take a committed antegrade attempt for once.
right. And this is
Let
the
us
type of
see.
case we were discussing yesterday, where you have a 50% osteal LMCA.
Yeah.
You can have an ischemia
Yeah.
of the donor vessel when you are in the midst of the procedure. So I would look into the
Yeah,
LMCA osteum again.
yeah. Well, it is not. We'll do that. We'll do that.
Yeah.
But pressures are okay.
So we
ECG
are
is
going
okay.
to watch
Patient
you
is
on the
otherwise
side
okay.
screen, Dr. Goel,
So that's
and
all
we are
fine.
going back to Dr. Hamazaki's lab.
Okay.
Yeah.
Yeah.
We'll
Okay.
come
So
back to it
I'll
sometime.
try antegrade.
Yeah,
Let's
we'll
see
come
what
back to it
happens.
sometime.
Okay. Yeah.
Ganesh.
Sure.
Ganesh, was there an option of using other collaterals? Because they would have served other
Yeah.
collaterals. There were distal collaterals which were also very good beyond the stent. If
Yeah.
you are committed to doing retrograde, just surfing one collateral and giving up is not an option.
I think because
Dr. Ganesh,
he didn't try the antigrade at all, so perhaps he's going back
Dr.
to that.
Ganesh, I feel that the angle of the EBU was not appropriate for the balloon to cross. Probably because it was too much towards the LED. A lot of time we see even doing normal cases, if your coaxial alignment is not there.
Yeah,
things
or
may
you can take a
tend
guide
to back out.
extension.
And as far as left main, I feel that left main has a little bend. Because earlier when he showed the angiography, there was a bend. in
And
that
there is a
left
lesion
main.
also there.
Possible.
Come on.
Dr. Goel, we are with you.
Okay. Yeah. So show from where we left. So as I told you, because of that stent there and the difficulty, so I said I will do antegrade committed. So always, there has to be as you know in CTO, a plan and change of plan. So initially it was only exploring the antegrade possibility, and then because of the good collaterals trying to go retrograde, but the stent thing obstructed it. I know there were some septals beyond, but what happened when you do live, that's what happened. And then to get to the next septal, I could have done that, but the connection of the next septal on microscopic examination was not very good. So then I changed to a committed antegrade strategy.
Okay,
So if
can you
I
tell
do
us the
committed
hardware?
antegrade, then I will escalate the wire. So then I used a Caravelle 135, and initially that XTA was not moving forward. And the main problem in this lesion is that the support is small because it is near ostial. There's a very small stump. The
What
voice
is
is
your guide
echoing with
catheter?
me. दो बार आती है आवाज.
Dr. Goel, what is your
Guide catheter is SAL for right corner. Guide catheter is 7 French SAL. I always use a SAL for right by and large, unless there is a special issue. So SAL guide, and then I withdrew it slightly to make it little more horizontal, and then with the Caravelle at the mouth, I changed from XTA to Gaia 1. I did not go immediately to a higher wire because of that bend. I wanted that I should negotiate the bend softly, keep having my feel of the lesion so that I don't go extraluminal, I don't go subintimal, or whatever you call it. So then the Gaia 1 moved slightly forward. Go ahead and show me the angio. Na pichla angio karo. Go back please. Okay. So now you can see it. So this is where we were. Move forward. No, you have already. Go back. There is a fluoro recording there. So, and then we did some contralateral injections to confirm the tip of the Gaia 1. The Gaia 1 did not cross the lesion. Okay, the Gaia 1 did not cross. You see, that's how it is moving. So it was the tip of the. Acha, this is after that. Go back 2 more frames. Go back 2 more. Go back 2 more. Okay, this is Gaia 1. And this is the contralateral injection to tell you we have still not reached there. Okay? We are already about 20 millimeters beyond, and we are still not. So that tells us how long the lesion is, at least 30, as I told you. Next injection. So confirming it in RAO, always orthogonal imaging. You see, I used to work in biplane lab in PGI. Here we have a biplane lab, but it's more for the radiology. It's tuned like radiology, so I am not very conversant. So I still do in single plane. So you have to do some more injections. Next. So then something came back. So then I knew Gaia 1 route. So this is Gaia 2 now coming. So I know it will go till Gaia 1 level and then move forward. And then we directed it gradually. Because I could, you with the feel, you can understand how tough it might be. And then a little support and you move forward. So this is the live fluoro. So that's how it is still there. Gradually it will. So that's real time. So the micro has been pushed forward to get some more support. And then with that support, it moved a little ahead. Now at this stage, it's very important to confirm where it is.
Yeah, so we need
Move
a
forward,
contralateral
next.
injection.
So now you get the contralateral injection. So LAO view suggests that it might be in, suggests that. But at the top, you see something on the side. So I wasn't very sure. Maybe it is just lying over the RCA in this view. So confirm in the next view, RAO. RAO also it is, if you see, you have to wait till the RCA fills. This is very important. So now RAO again, you see it is there, it is in. So 2 views, if it is in, that means it is in. Next, forward please. So now I am comfortable, so now I just move this wire forward. That's again a live fluoro, and now it will move forward within the lumen. And you have to do it slowly. You can't, because if you push it hard, then it will, guiding catheter will again back out. And then advance the micro catheter over it. No, next. And then advance the micro catheter, and well, it did go. So that was okay. And then we changed to a workhorse wire, and that is where we are. I think I have just done a 1.2 dilatation.
Okay, so we'll
I
let you
have
work
just
here.
done a 1.2 dilatation. So you just see that it flows. I think I have done the dilatation. Come on. So some flow is resuming. Okay? So I'm sure we'll be able to now get through.
Yeah.
Okay?
So you managed the antegrade wiring.
Dr. Goel, sir, I have one
Yeah.
question for
So
you.
what the message from here is, always there has to be switch between techniques. And you have to switch at the right time. Now, at that stage, I could have persisted on retrograde, trying to get another channel, but that's not so I then consciously said, let me give a wholehearted attempt to antegrade.
Yeah.
So antegrade sometimes will succeed when retrograde fails.
We have a
Goel,
comment
You
from
get
the
it?
panel. Go ahead.
What I want to ask is, let's say you had a difficult proximal RCA and ambiguous origin, and you had to go through the same channel. What would have been your approach in that case? You would not, because everything was backing out. So how would you have managed?
I would have got a guideliner into the left LAD, and with that guideliner, a new low-profile balloon, 1.2 or something again, and dilate one of the stent struts. And once the stent strut is dilated, then the gear will go.
Sir, is it possible
Then the
that
gear will go.
when you deployed the stent earlier, probably the distal part of the stent would not have expanded enough, or you could keep an alternative wire in the LAD and give a balloon
No, I
dilatation, then
don't
try?
think so. I don't think so.
So because
No, 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 no. I will not touch that thing. That is, no, can I just tell you? I know what you're asking. I will not touch the LAD at this stage, which is already well-healed LAD, and this was done with a rota. I could not show you that rota thing, but this was done with rota, and I was in fact wanting the stent to fall short of that septal because I had it in my mind that I will be needing to use the septal. Hey, don't pull. But then the lesion was just at that level, and then there are 3 septals there, and we analyzed them pretty well on the angio as to which one has the continuity. So the first one had a continuity through that posterior branch where I went in, and then the second one doesn't have the continuity, then the third one has the continuity.
so you go by that
So-
notion that we should try first integrate full-heartedly and then think of going retrograde, or straight away go to retrograde?
No, 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 no. Depends on the anatomy. This anatomy, I would still, next time also try to go and retrograde only. Because this antegrade is not easy. The stump is very small, you don't have support, and it is a little longish lesion, and the lesion is across the bend. So that is the issue. Now, because retrograde was creating difficulty for me, so it is like necessity is the mother of invention. So because that was creating difficulty, then I went wholehearted antegrade.
Sir, hello. Sir, 2 questions, sir. When you know you are there
Yeah.
good septal,
Yeah.
so going ahead, stenting fast, is it ideal? And second, now you have nothing to do with your retrograde. Can you take your guide out and put a diagnostic catheter because we are suspecting something in the left main?
Yeah, I can do that. I can do that.
he
I can do
it in
that.
the-
I can do that.
While
In
you are
fact, I
working
don't
here,
need the left.
Dr. Goel, we are just visiting the other cath lab. We'll come back to you very soon.
Okay. Basically, I am now doing ballooning of all that, and there's all that long segment disease. Can you see that?
Yeah, did you
I
do
had
an
to
IVAS after this?
use a. No, I have not yet done the IVAS.
Because of the extensive disease,
My plan is to do the stent. Yeah, my plan was to do the stent and then do maybe OCT if that is okay.
why don't you want to do an IVAS?
but
here?
as far
It's a
as the
chronic lesion.
CTO
we need to get the right size of the vessel. What is
come on, Karo. So, you see, actually the CTO vessels come out all diffusely diseased. So my thought is I must first fix the proximal part, which is the true occlusion, and then work it out. Okay, it may need some more
So what size,
work
how will you
to
size the stent
understand
in this case? I mean,
how much.
without the IVAS.
Actually, you see, we have a study, I don't know whether you've seen that, I've done a study trying to compare IVAS size and angio size. So this angiographically looks about 2.5 or so, 2.6. I think I will put at least a 3 millimeter stent here, because we have a calculation that the true size is about 0.6x on the angio plus 1.3 or something
why
like
the
that.
guesswork? Why not
So
quickly
roughly,
run an IVAS?
I can always do that. That's right. That's right. But what I'm trying to tell you is, if you have an idea of, there is a general correlation between the angio size and the true size. So you can do it like that, but we can always do an IVAS. You want to show an IVAS? Come on, Lau.
Yeah, we would like to see the IVAS.
I can
because,
show you the IVAS.
We still feel the proximal
Okay.
RCA can be 3.5.
Distal looks around 4, actually, after RV.
Yeah, it might be. It might
Yeah,
be.
distal after
It
RV
might be.
looks around 4 millimeter, actually.
Sorry, what looks 4 millimeter?
After the RV branch,
What
the
looks
vessel
for?
diameter
It's
looks
not 4
pretty big.
millimeter.
Doesn't look 3, actually.
I mean,
No,
let's
I
look
don't
at the
think.
IVAS.
I don't
There will
think
be
it would be
no
4
distinct,
millimeter, but
Better
yes.
do an IVAS, yeah. Doesn't look 3 from any side.
Who is this? No.
You have pre-dilated with a 2.5 balloon.
Wait, thoda wo de do. Yeah, I've done with a 2.5 balloon. Yes.
Okay. And you have pre-dilated
atropine
the
de do
CTO
aur wo de do.
segment, and you have not touched the mid and distal RCA. That's where you are, right?
I have done a low pressure on the distal also. I have just done a low pressure on the distal
Okay.
because distal was pretty diseased, you know. Gave some nitro and stuff, and then no. Let us see what the IVUS shows.
You have any comments from the co-chairs or panelists? Any questions?
Actually, you know, this being a CTO meeting, we should, I thought we should have more discussion on the CTO thing rather than the,
No, the
because
importance
these are all
IVUS
part of
in
standard
CTO
angioplasty which can
evaluation
be.
cannot be, I mean, debated.
IVUS is integral part of CTO assessment. most
Yeah,
important.
you see,
Without
because
IVUS, we should not,
IVUS, you know, if it is
completion
subintimal,
is
you want to,
incomplete.
if it is subintimal or something, then you look for the IVUS. If you have to
In
do
fact,
antegrade
maybe
side
you should
branch
not have done
based
even an antegrade
penetration, then
injection, and you should have done an IVUS primarily, because that way.
no, I don't believe in that. Who's that speaking? You see, that depends on your conviction
So you
also.
believe that you should, even
I
after
won't.
doing an antegrade wire escalation in a CTO, you believe that you should inject antegrade
Huh.
to see the, and not do a contralateral injection or do an IVUS examination?
You see, well, no. Hey, don't.
That is
No.
Dr. Adil Dalmari.
Contralateral. I'm always doing. Contralateral. I'm always doing. So once it is opened, and I have done. You see, contralateral. I'm always doing. The point is to size it on IVUS. Well, I am not so. And some people may even say that you do like contrast-free angioplasty.
Low contrast.
Well,
While you
I don't. I'm not too.
I think it will take another 2 minutes to set up the IVUS.
You're setting up the.
We'll just
Yeah,
see the other
yeah,
lab
yeah.
and come back. We are watching the IVUS by the side.
Yeah.
Where are
So
you?
now you see the size is about 2.75, 3, 1,
This
2,
is
3,
3.5 now.
3.5. Yes. Sir, in RC, I will not put 4.
Where is your IVUS
whatever
catheter
you
right
say.
now?
It is here. 1, 2, 3. 3.2. 3 point. There's calcium there.
Dr. Goel, which part of the right coronary artery is the IVUS?
Yeah, here it is. Can you see that? I'm showing you the fluoro.
Angio we can't see.
It is about 20. It is about, now it looks bigger. Now it is 1, 2,
Yeah, we only see the
3.5.
IVUS. Where is your IVUS catheter?
Yeah. It is very close to the mouth now.
Okay, so,
Very close to the mouth.
right. So would you agree now that you will take a 3.5 stent?
3.5, yes.
Yeah, we can take a 3.5.
Yeah,
That's
okay.
okay.
Okay, so.
But no 4. No way I can use a 4.
Yeah, 3.5.
Because
So
distally it is 3.
Your IVUS has changed the
Actually, in a
decision from
situation
3 or
like this,
stent
I'll tell you what. No. I'll tell you what. What I would have done, still maybe taken a 3 and expanded it to 3.5. You see, you have the leeway that otherwise there's no point because there's a long disease, long segment stent. So if I start 3.5, it will be distally also 3.5. We saw reasonable 3 millimeter areas in the distal part. So I would still feel I'll use a 3 because I may use a 38 or a 48 stent. So I can use a 3 and post-dilate it to 3.5, no problem.
So I perhaps
That's much
some of
better
us
rather
would
than-
have done an IVUS only after pre-dilating the
Angio?
CTO body and not taking the balloon low down into the RCA.
You see,
and
the
then
vessel
take us-
looks rather thin to me on the angio. I will use a 3 millimeter stent and
Right,
then post-dilate
okay,
it
we
if
take your
required.
point.
348.
Dr. Goel, thank you so much.
348.
It was an excellent demonstration of
Yeah.
antegrade approach. We'll go back to the other lab for the final
Right.
comment from Dr. Hamazaki. Thank you so much once again. Over to Dr. Hamazaki for final comments from him.